Now we move to the tumors of the dermis. So there are only two entities in your book now that we're going to cover. Benign fibrosarcoma or dermatofibroma, dermatofibrosarcoma protuberans. So we'll only discuss those two. But there are a lot of tumors that involve the dermis. So those will be probably tackled in the discussion for the soft tissues, bone and soft tissue tumors. So most of the tumors that can extend from the underlying subcutis or muscle that extends to the near to the skin. But the two primary entities that are thought to arise from the dermis are those two in a row. So the dermis is usually composed of smooth muscles, fibroblasts, peristaltic tissues, and epithelium. Neoplasms can arise from those elements. And the first entity is the dermatofibroma or benign fibrophysiocytoma. You'll see later why it's called that way. So these are tumors of uncertain lineage, so we don't know where they come from. They may come from fibroblasts, they might come from macrophages. As of now, we don't know. But definitely this is a benign lesion. So it's just easily excised once confirmed by biopsy. Usually found in young adults, commonly females, and they are usually asymptomatic or they may be slightly tender, and parang it increases and decreases over time. It's an indolent tumor, so it may just stay as it is. In terms of its molecular cytogenetic makeup, a portion of these tumors have ALH infusion, and that could explain its neoplastic origin. However, a majority of these tumors have no specific genetic mutations. So they are usually painless fertile to brown papules and usually 5 to 2 centimeters in size. So it's a very small lesion. And under the microscope, this is what you see. So this is from one of our patients. You see a well-demarcated tumor consisting of spindle cells. So the epidermis rather they're benign. There's some active process going on, but generally no changes in the epidermis. And notice that the cells are arranged in what you call a story form or parang star-like pattern. So you have two more cells going here, cells going here, parang star like this. That's what's called as a story form pattern. And what you see are the cell population. So it has a varied cell population. It's not just simple fibroblastic spindles. But we also have these. It's not clear here. You can see these cells that are large and pseudonuclei and parang pale. Cytoplasm is pale and granular. These are your foamy macrophages. So in this tumor, you have varied cell populations. Macrophages, fibroblasts, and that produce collagen. And one unique feature in this tumor, as you can see here, this is what you call as collagen trapping. So it's not an invasive feature, but rather it traps the collagen between the tumor cells. So it's not usually seen in other tumors of the dermis. So remember your collagen trapping. So this is an entirely different entity. So dermatofibroma does not become a malignant lesion. Dermatofibrosarcoma protuberans is a neoplastic tumor, well differentiated, locally aggressive, but does not usually metastasize. So like it's dermatofibroma, it's slow growing, but it does not arise from a benign lesion. So as you can see, it's usually larger. It's a larger firmly durated plaque and sometimes an ulcer and be mistaken for epidermal lesions, epidermal tumors. So here you can see the tumor is rather deep-seated. So this is a cross-section of the tumor, rather solid homogeneous lesion. And here, it extends toward the subcutaneous fat. That's the difference between a dermatofibrosarcoma and a dermatofibroma. Dermatofibroma is usually just in the middle dermis, and this will not extend lower to the subcutaneous area. So, see, this one is neoplastic, definitely a neoplastic growth. So you have gene fusion mutation, you're called 1A1 and PTGFB fusion. So this gene fusion causes overexpression of your platelet-derived growth factor beta, which causes cellular proliferation. So note the gene fusion involved in this tumor. And since it's a well-differentiated lesion, as you can see here, it's also one of our cases. As you can see, it insinuates itself between the fat. So it's a deep-seated invasive lesion. So the fat cells are in between the tumor cells. And this lesion can have pigmentation, but this is not a melanocytic tumor. This, because in melanocytic tumors, the pigments are melanin. In this one, this is hemosiderin. These are hemosiderin pigments. You see the trapping of the tumors as insinuating between the fat cells. No? So it's similar to what you see in your book. This is what you call a honeycomb pattern. So here, this insert here is from your book, and also this one has a story form pattern. But instead of being composed of different types of cells, you have this. They're neoplastic tumor cells that are uniform, rather uniform. They appear the same. Their features are rather somewhat mildly atypical, but not really that striking or different or what you call pleomorphism. There's rather not very much variation in their size and shapes. And again, they have this story form pattern. No? So look, so may they're going here, here. Another one going down here. And sometimes, well, most of the time, these tumors are difficult to differentiate from other spindle cell tumors that involve the dermis. So sometimes spindle cell tumors, soft tissue tumors, that arise deeper in the muscle and fascial layer can extend to the dermis and can be mistaken from each other. So one tool we use immunohistochemistry, like I discussed before. So these tumors are typically immunoreactive, diffusely positive for CD34. So you can see this tumor was stained with CD34. There's diffuse expression, and this is how you differentiate it from your dermatofibroma. CD34 is usually negative for dermatofibroma, and this tumor, this dermatofibrosarcoma, does not usually stain for nerve markers like S100. It does not stain for melanoma markers such as HRB45, melan8. So that's how one ways we can differentiate it from if we cannot distinguish it histologically. Okay, now we move on to the melanocytic tumor. So it's much more fun. So tumors that involve the melanocytes or your melanin-producing cells in your basal epithelium. Okay, so you can divide your melanocytic tumors from your lentiginous lesions, your more benign melanocytic nevi, nevus, and your malignant melanomas. Okay, let's first discuss lentigo. Lentigo is a common, benign, localized hyperplasia, so increase in number of your melanocytes. That's it. Increase in number of your melanocytes. If it's found in young individuals, you call it lentigo simplex. And in older individuals, which is usually associated with sun damage, we will call it your solar lentigo. And histologically, we can distinguish it. Exact pathogenesis is unknown. You can see these either macules or patches that are brown, no? So they're not elevated. Histologically, you will see this, no? Hyperpigmentation of the basal layer, indicating increase in your melanocytes. So the difference here from nevus is that there is no nesting. Later you'll see what I mean by nesting. So there is no nesting pattern of melanocytes. No inflammation, as you can see here. There may be pigmentation. This one in the dermis are actually what? These are macrophages that phagocytize the melanin. So these are your melanophages. No? Here. So this is not a tumor. These are not malignant cells. These are just your macrophages that eat the excessively produced melanin. Here, more in the earlier was simplex. This one is solar lentigo. You can see here distinct elastosis again. Elastosis, a sign of sun damage, increased elastin production in the dermis. No, but as you can see here, increased hyperpigmentation of the basal layer, but no nesting. So this is solar lentigo. And we have lentigo that is associated with certain syndromes. No? Your Fitzgerald syndrome. So your Fitzgerald syndrome is the appearance of hamartomas polyps in your GIT. No? And they can have also the appearance of lentigos, multiple lentigos in skin and in the oral cavity or in the lips. No? Mucocutaneous involvement. Kasi typically in a simple lentigo, it will not involve the oral cavity. So again, there's your Lempart syndrome and your Carney complex. So just some examples of lentigos that are associated with certain medical conditions. I will not ask this in your exam. Okay. We move now to your common nevus, or colloquially known as nodes, nodal. So these are just benign growths of melanocytes that form initially hyperpigmented macules and then they become papules over time. They have well-defined borders. Note the definition of a mole. So well-defined borders. The skin, the color is uniform. So that's important when you distinguish it from more neoplastic melanocytifications. So there is acquired mutation in the RAS signaling pathway, and this is the most common form of nevus. So a person typically seen in most people. So note the well-defined round borders, uniform color, and this will not rapidly grow. So no rapid growth involved. And this is in your book. So I included a picture from your book here and histology examples. So this is the development of nevus or nevi oral. First, this is your normal skin. These are your dendritic melanocytes in the basal. So you don't really see any hyperpigmentation. And then they become junctional nevi. So this is what I mean by nested pattern. So nests of benign looking melanocytes which can be pigmented or anti-pigmented. Now, junctional kasi is in the junction between the dermis and the epidermis. Then we look there, compound nevi. So compound meaning there is a junctional component and a dermal component. That's why it's compound. So this is your dermal component of nested melanocytes. Here, and junctional component of nested melanocytes. But the melanocytes here are rather uniform. There is no mitosis, there's no mitotic activity, meaning they're not rapidly dividing. They are not atypical, they're uniform. Look, note the uniformity. And now, this is your a more nodular appearance, your dermal nevi. So this is from an actual patient. You see, no junctional, no nesting of melanocytes in the epidermis. But look at the dermis. So So nests of melanocytes in the dermis with pigmentation, but still no atypia. The cells are rather uniform. They're benign looking. And look at the clinical appearance. No? It's a typical mole. And this one, what do you call this according to the book? The last stage of nevus development. They appear like nerve cells. Neurotization. This is neurotization. So now the pink appearance of the cytoplasm, and they become like spindle, parang serpentine nuclei. So this is just neurotization, and this is an important feature when you want to distinguish a lesion as a melanoma versus nevus or more benign melanocytic lesion, because melanomas will not have neurotization, because neurotization is what? It is a sign of maturation, and melanomas do not undergo maturation. So not that neurotization kasi you look for it in the deeper layers of the mold. So when you have a suspected melanoma and you see this one, neurotization, so parang you say, probably not a melanoma, or if it's a sign that it's maturing. This is your congenital nevus, no? Can be mistaken sometimes for melanomas because of their deep-seated involvement of the dermis. So, as distinguishing characteristics of your congenital nevus is rather deep, no? Almost near the subcutis. The nests are almost here in the deep layers of the dermis, but still benign looking. And congenital nevus have a more propensity to progress to melanomas than your acquired nevus. Sa bata. Your Spitz nevus, so rather than being epithelioid or dendritic shape, they are more spindle, the Spitz nevus, and usually affect young adults and children. Does not typically have BRAF or MS mutations. That's why it's a distinct entity from other your common nevus. It has HRAS mutation instead. Now later I'll show you how these mutations are involved in melanomas and melanocytic lesions. So it can recur, unlike your common nevi, if the margins of excision are it's not fully excised. So this is from one of our patients. So look at the difference between a Spitz nevus and a common nevus. It's rather reddish papule. Reddish papule. It doesn't look typically like a nevus. Because this patient was actually thought ang lesion niya was this is from a 12-year-old female who had a reddish papule near the eye. So it's thought to be a pyogenic granuloma, from trauma. But when we looked at it in the microscope, so we saw spindle nest, but they're rather benign looking. There's no atypia, no mitotic activity, no necrosis. In this case, no maturation, and look, very well demarcated lesion. You see this, parang you can from lower magnification, you can see the distinctness of the lesion from the normal, the epidermis of the dermis. Well demarcated, because melanomas are not well demarcated lesions. And you can see this nest, there's nesting of, instead na round sila or polygonal, they're more spindle. That's what we call Spitz nevus. And there are variations of the Spitz nevus. They can be atypical Spitz if they display some level of atypia. And they can become spitzoid melanomas, so more malignant spindle melanomas. These Spitz tumors usually have a propensity to become malignant. So this one is your atypical Spitz. So compare this one from this one. You see the variations in the shapes. And look at the nuclei. They're rather dark. And the typical nesting pattern are not really seen here. And there's this one, what's this one? This is mitosis. No? This is a metaphase. No? Nag-align siya in the center. And this one, you don't see mitosis. Other melanocytic lesions, your blue nevus, because note the distinctive blue. Can you appreciate the bluish hue? Also does not have BRAF or inverse mutation but has GANA mutation. Later, I'll clarify the mutations. But it's actually in your book. This is what you will see. So your spitz nevus, like your spitz nevus, they're also spindle. But the spitz nevus is usually amelanotic. So they can be mistaken for other entities. Kasi wala kang melanin. But this one is your cellular blue nevus or blue nevus is because of this this usually pigmented or hyperpigmented na lesion. So look, there's no junctional activity, so it only involves the dermis. So it's an intradermal nevus. And there's a variant of your blue nevus called your cellular blue nevus. So there is more cellular. This one is your typical blue nevus. So spindle cells that are rather benign and have pigmentations, and this one is your cellular blue nevus. This one is more common in younger males and also has more propensity for progressing to melanomas. So usually in excised lesions. Now we move to your still a benign, but rather dysplastic na siya, meaning there's abnormality in the growth. So your dysplastic abnormality in the growth, your dysplastic nevi. And compared to your common nevi, this has an increased risk for developing into melanomas. So it's important that it should be caught in the biopsy. And look at the appearance of it in its clinical appearance. Note the irregularity of the border. And there's rather difference in the color. So this was more brown. This was a darker area. So parang may variation in the color of the melanocyte. No? It has BRAF mutations, but also CDKN2A mutations. So it's a cell cycle protein that causes progression of cell growth. So irregular cell borders, larger than 5 millimeters, variable pigmentation. But most lesions are stable and do not progress. But it's important to not catch this early on. Kasi not all will regress, or some will become melanomas. And this is what you will see in the biopsy. I put here a picture. This is what kanina, your junctional nevus, diba? So like your junctional nevi, the dysplastic nevi has a junctional or nested growth pattern. But note the difference in the nest. So you have the nest here, your junctional nevi. This is a nest here and the nest here. But what happens in your dysplastic nevi? There is merging or bridging of the melanocytic nest. So this is what you call as bridging of junctional nests. So compare here, the cells are more atypical. They vary in shape and size. No? This compared to this one, rather uniform. And there could be some mitotic activity. So note, dysplastic nevi, junctional nevi, benign, pre-malignant. Okay? Okay, now we go to the more malignant, the malignant ones, the melanomas, or malignant tumors of your melanocytes. Usually related to UV radiation or sun exposure. But later you'll see that not all will be involved with UV radiation. Primarily it is a skin tumor, but melanomas can arise in other parts of the body. I've seen a case of a primary melanoma, the brain. No? There are also cases wherein melanomas can arise primarily from the GIT without any skin lesions. But melanomas are typically metastatic lesions. So it's one of the most widely studied lesions, widely studied tumors. So we were able to find out the numerous mutations that are found in melanomas. No? So you have mutations that disrupt cell cycle progression, mutations that activate growth signaling pathways like glycosamine, and mutations that activate telomerase, or your third promoter mutations, meaning there's elongation of the telomerase, increasing the life of a cell. No? That's actually the third. You have elongation, telomerase elongation. Melanomas typically metastasize to the lymph node and brain. No? But the case that I saw na primary melanoma of the brain did not have any skin lesions, and it occurred in a child. So this one, what's this? Okay, let's break this down. Is this familiar to you? Several things. Chapter 7 of your Robbins, molecular basis for neoplasia. So this is your typical tyrosine kinase. So it's a bit small. This is actually from my notes. So I incorporated the diagram from Robbins and then added all the little diseases that arise from this mutation. So this is your tyrosine kinase receptors, tyrosine kinase receptor pathway. So signaling. Kita niyo ba yung mouse? So mutations in your melanomas have in the RAS signaling. No? So once a receptor binding of a ligand, the tyrosine kinase receptor, causes activation of your RAS. So your RAS is a downstream secondary messenger that promotes cellular growth and cell cycle progression. No? So itong very complicated pathway. So the mutation is here in your RAS. So these are the genes, the proto-oncogenes that are involved in melanoma that cause activation of the RAS. So normally, to activate your RAS signaling, you would have a ligand, a receptor that binds to a ligand that binds to a receptor. So that depends on the growth factor. But anyway, it causes activation of your RAS. So what happens in a mutation in this KRAS, HRAS, and RAS? Can you see? Okay lang. Can you see? Diba? Hindi nyo kita. Sorry. So anyway, yung mga KRAS pagalaki ito para ma-appreciate mo. Kasi these mutations are actually involved in a lot of tumors. Para sorry guys, I don't know how to enlarge it or zoom in further. Anyway, basta these proto-oncogenes activate the RAS. So instead of having a ligand binding to a receptor, you have independent activation of your RAS pathway. So mutations in your KRAS, NRAS, HRAS genes that code for specific RAS proteins will have independent activation. So you can see here your NRAS, HRAS, GANAC mutations are involved in melanoma. Further. Anyway, activation of RAS and eventually downstream signaling to activate your PA3K, AKT pathway that involves in cell growth. This one. And there are also mutations here. One of the most important mutations, your BRAF, because this one is usually seen in Filipinos. Your BRAF mutations. BRAF, B600, can you see yung BRAF, B600 mutations? So one of them is in melanomas, malignant melanomas. So this one naman, your MPK activates your MPK pathway that is also involved in cell cycle progression and growth metabolism. So a mutation here is an independent activation. So there is no signaling that occurs from upstream that requires it to be activated. So it's just an independent activation. That's why you have what you call as your gain of function mutation. No? Gain of function mutation in your RAF pathway. Here. So another pathway that's involved in melanoma is here. Your cyclin D, CDK pathway. No? So this one controls your RB. Diba, RB is a parang called the gatekeeper for progression. Look at RB, no? So RB is the one that prevents the cell from progressing from G1 to S phase. No? And when RB, look at yung RB, there's an RB that has a red dot. Can you see? Yung RB na meron. That means the RB that's phosphorylated. Once RB is phosphorylated, it means it does not function as a gatekeeper anymore. So the cell progresses in cell cycle. No? And what is responsible for the phosphorylation of RB is the binding of your cyclin D proteins and your cyclin-dependent kinases. Once that occurs, you have phosphorylation of your RB, so cell cycle progresses. Now, what happens in melanomas? Di ba meron tayong mention kanina, CDKN2A mutations. No? So you have mutation here in your cyclin D that causes activation of this pathway, meaning the progression and the phosphorylation of your RB can occur, so the cell cycle progresses. Gets niyo? Questions? So this is actually your book. This is all in your book. It's in chapter 7 of proteins. No? So what happens? No, in melanoma, it says, it's ano nito. Do you want a copy of this?
Yeah.
Yes, I'll give you a copy of this. No? So there are mga numerous cancers that are involved in this pathway. No? No, melanoma is just one of them. So in melanoma, you can see here, wala kasi na akong pointer. You know, CDKN2 mutation. No? May pointer. Thank you. Thank you. So here, yung CDKN2A kasi is a gene that codes for your CDK inhibitor. So these are the ones that prevent the binding of your cyclin D and CDK4 that will allow RB phosphorylation. So this one will prevent the phosphorylation of RB kasi it will prevent this one from binding. But when you have CDK2A mutations, there's what? There is loss of function naman. Kanina, function, your RAS pathway, your BRAF, this one is a loss of function of the inhibitors. So the binding of your cyclin D and CDK can occur, and RB is phosphorylated, cell cycle progresses. Okay? So this one is seen in a lot of cancers and includes melanomas. No? Ito natin kanina, para yung mag-isip pointer na. Thank you very much. Again, RAS activation, NRAS, HRAS, GANA. This one involved in melanomas. BRAF, this one, B600E mutations, RAF activation naman. So, yun. Your pro-growth, signaling pathways, and cell cycle progression. Sorry, yung have the third promoter. Diba? Third, your telomerase elongation causes elongation of the telomerase. So the longer the telomerase is, the more the cell can divide. No? So a third promoter mutation means the cell keeps dividing. That's basically a third. So those are the three pathways for melanoma mutations. No? Disrupt cell cycle control, CDK2A, and then your pro-growth signaling pathways and telomerases. So these are the mutations involved in melanoma. There are a lot of studies that went into melanomas kasi the treatment for melanomas are now directed against these pathways. Especially yung BRAF. Kasi later, makikita natin why is it important for Filipinos. Now here we have your classification of melanomas according to WHO. So they are divided into high cumulative sun damage, low cumulative sun damage, and the ones that are not related to sun damage. And where do we as Filipinos are here? We're here, no? So here these are the melanomas that arise from your spins, from your blue nevus, now your acral melanomas. These are the most common. Acral meaning the non-sun exposed regions. Kaya natin ang acral melanomas. So, palms, soles. No? And later we'll see cases of that. No? So, your high cumulative sun damage, your lenticular melanoma, and your low cumulative sun damage, your superficial spreading melanomas. And the nodular melanomas are divided to either one of them. So, from your book again, the progression of melanomas. You can see here, normal skin, deteriorating melanocytes, and you can have your junctional growth, junctional nevus. And then, a bit of caveat, disclaimer. When we are able to diagnose melanomas, usually nandito na sila in the more advanced stages. It is not yet clear how and why these lesions progress to this one. This is sort of a theory of how it happens, but we've never actually, or only a few cases of junctional nevi that progress to melanoma. But the dysplastic nevi usually can progress, but not usually. So this is dysplastic nevi, irregular cell borders, you have your bridging, no? Bridging of melanocytes here. Ay, hindi kayo kita. Weird kasi na set up. Dito naman ako para hindi bias. Sorry ah. Weird set up.
Kunan pointer na lang ang laptop.
So again, no, bridging of your melanocytic nests compared to your junctional separate nests. So this is dysplastic. And then this one, now melanomas have two growth phases, your radial growth and your vertical growth phase. Now the tumors that display, para fair naman na. Yan, okay na. Sorry about that. So this one, no, the appearance, can you see the appearance of melanomas? Irregular borders, irregular shape, variegated or variation of the color. So, ibang color, the more blue, some more brown. No? Those are signs of melanoma. And this plastic one ito. But usually the melanomas can become bigger, but not all the time. So this is your radial growth phase. Radial growth meaning it goes along the axis of the epidermis. No? This is your superficially spreading melanomas. No? There's atypia, mitosis, that there's no nesting in superficially spreading melanoma compared to your lentigo-maligna melanoma, which has junctional and compound areas. So superficially spreading only in the basal, no nesting, but atypical ang cells. This one, this has junctional, so nesting. So lentigo-maligna melanoma, superficially spreading melanoma. This one, melanoma in situ. Now, weakened with various immunohistochemistry stains to differentiate melanoma from dysplastic nevi. Usually, they have the melanomas of higher proliferative index. We use Ki67, WIG1 to distinguish them from other lesions. Kasi dysplastic have low proliferation index. FYI lang yan, that's no lang yan. But aside from histologic appearance of the tumor, we use also IHCs. And this one is your vertical growth phase. Now, diba, ang growth nito from the your lentigo and lentigo maligna melanoma and superficial spreading along the axis of the epidermis. This one is nesting, ito wala. The vertical growth phase, as the name implies, meaning this now more downward growth. Downward growth of the tumor, usually, nodular na siya. Nodular melanomas. So, nodular melanomas have vertical growth phase na. So when melanomas are diagnosed, they are usually diagnosed at this phase na or here. But there is no parang direct evidence of a junctional nevi that will develop into a melanoma. But this is what is thought to progress, meaning hindi mo lang pinapansin na mo, it's already melanoma. Most likely, it's already a melanoma from the start. It's not a nevus from the start, it's already a melanoma from the start that progresses. I just put the picture of a junctional nevi here to as an example, but kung junctional nevi siya diagnosed, junctional nevi na talaga siya. Okay, now, these are the melanomas that are not usually associated with sun exposure. So your acral melanomas, acral, so arms and soles. No? So this is actually from our patient. This is the patient from Samar who came to us with a nodule, a large tumor on the sole of the foot. Now, at first glance, you don't think melanoma, di ba? It's rather brown, not really pigmented, more fleshy. There's areas of greasy, participated material. First thought here was squamous cell carcinoma. Now, in acral melanomas, the non-sun-exposed, non-hair-bearing areas, and these are the common melanomas combination. Asians and Filipinos, non-white. Kasi usually melanomas is from Caucasians, lightly pigmented people. In my, I've not seen a superficially spreading melanoma or lentigo maligna melanoma in a Filipino. Pero baka, nagkataon kasi compared to the three primary skin malignancies here, basal cell, squamous cell, and melanomas are much rare in the latter. And overall, it's rare in Filipinos. But if it does occur in Filipinos, it's usually acral melanomas, which is not related to sun exposure. Filipinos will develop skin cancer, usually basal cell or squamous cell. No? And look, BRAF and NRAS mutations are more common in acral melanomas. So this one, this is the histologic picture of the patient. Note the vertical growth, so downward growth, nested melanocytes, no? Here, and you see atypical, screen. Anyway, there's atypia, so iba-ibang shapes and size. So they are big. This one, look, this very big cell here, giant cell na siya. And then there are smaller ones, variations in shapes and sizes of your malignant melanocytes. So they can also become spindle. So if they are epithelioid, round, polygonal, and spindle. So that's a usual picture of melanoma. And in this case, there's no pigmentation. So that complicates the diagnosis actually. It's an amelanotic melanoma. And this one is from another patient. Same thing, mass in the foot. Excuse me. Mass in the foot, nodular, vertical growth pattern. And as you can see, look at the difference in the cells here. Look at the cytoplasm, they're pink. Melanocytes have rather darker bluish cytoplasm, but this one is pink. And that another complicates our diagnosis for this particular patient. And it looks like a squamous cell carcinoma. It's pink. like your keratinocytes. Initially, the diagnosis here was squamous cell carcinoma, uh, na acantholytic type. They're part of the acantholysis, liver acantholysis, separation of the keratinocytes from each other. But look at this. This is actually S100 and melan A. Markers specific for melanoma that will not be positive for squamous cell carcinoma. So we were able to diagnose this case as a rhabdoid type of melanoma, rhabdoid variant of nodular melanoma. Oh, sorry, acral melanoma. So if you didn't do the IAC stains, we would not know the specific diagnosis. And sadly, the patient developed metastasis to the brain because it's melanoma. Melanomas are very metastatic, either to the lymph nodes or to the other organs. Nag-develop na siya ng metastatic to the brain. Sadly. Okay, so this is what I was talking about. Your the ABCDEs of melanoma. So this is in your book. This is found in all Andrews province or Arizona. ABCDs of melanoma: asymmetry, irregular borders, variegated color, nasisig kanina, di ba? May brown, may blue, iba-ibang color, black, and then usually more than 10 millimeters, as you can see naman kanina sa patient natin na in the foot, very big tumors, and not the evolution or change in time. So a nevus does not change. It can be there throughout your life and it will not change in appearance. But a melanoma does. And the treatment for melanomas, I was explaining yung molecular pathways earlier, your BRAF, your promoters, and your CDK2A pathways. Because the treatment for melanomas are not targeting those mutations, your BRAF inhibitors. They inhibit your activation of the pathway. The immune checkpoint inhibitors are also used in other tumors, yung mga PD-L1 treatment. We have special stains to identify a patient eligible for PD-L1. So it actually, these immune checkpoint inhibitors are that allows your actual immune system to fight the tumor. So, di ba dati we treat cancers based on yung mga chemotherapy. We target the cells, the rapidly dividing malignant cells. Now we have your immune checkpoint inhibitors, yung PD-L1, your pembrolizumab. They're the ones that help yung lymphocytes mo, your cytotoxic CD8 lymphocytes to attack the tumor cells. Kasi the tumor cells have a way, so they have your PD-1. They have PD-1 that inhibits the binding of your lymphocytes, your cytotoxic T cells, to the tumor cells. But the PD-L1 inhibitors, yung mga immune checkpoint inhibitors, they will prevent that. So they will allow your cytotoxic T cells to attack the tumor cells itself. So that's now the current trends in treatment of cancers. And you will learn that in detail sa medicine, sa oncology na these are bagong treatment cancer care. No? So mutation, attacking mismo the receptors that promote cell growth or helping our immune system fight off the cancer. So the pathologic features, so that's why we examine melanomas carefully because they are used to predict the outcome of the disease and potential metastatic ability of the tumor and response to treatment. And this is how we sign out a case of melanoma. So we put all this information for the clinician, so the clinician knows if this melanoma will respond to their treatment, if this melanoma has a potential to metastasize. So you put there the breast lobe thickness, the thickness or the diameter of the tumor. Clark, not so much. Clark is just the level, epidermis, epidermis, superficial dermis, down to subcutis, may mga levels sila. So when you say Clark level 4, meaning it's already near the subcutis. we put the mitotic activity, so one of the prognostic markers. So the higher the mitotic activity, the more proliferative and the more metastatic the lesion. No? Ulcerations present, microsatellites, meaning there are other tumors that grow from the adjacent to the primary tumor. Neurotropism, kasi if there's neurotropism some way, but I have not seen neurotropism actually in before yet. Kasi if there's neurotropism, there's maturation. So it's actually a good that there is neurotropism. But in this case, obviously there's no neurotropism. It's malignant melanoma. No? So we stage it as stage 4. So this was the diagnosis of the patient. So it's not enough that from a pathologic standpoint, it's not enough that you put the diagnosis, the histology. It's all those important pathologic features that need to be placed in the report so as to guide the treatment of this patient. So it's also in your book, no? The breast low thickness, mitotic activity, the presence of tumor infiltrating lymphocytes. Kasi if there is tumor infiltrating lymphocytes, these are the ones who are candidate for mga immune checkpoint inhibitors. But we actually use immunochemistry to test that. But we have to report if there's lymphocyte. Kasi if there is no tumor infiltrating lymphocytes, then it's a bad tumor. Kasi you have no immune response against the tumor. So the tumor is adapting to our immune system. So note na lang na yung breast low thickness, mitosis, tumor infiltrating lymphocytes, lymphovascular invasion and neurotropism are one of the yung ulceration also. Yan ang note ni Robbins na features that have that this tumor has potential to metastasis. And in this case, nag-spread na yung tumor. Okay. So that ends melanomas. Any question for melanomas? Hindi mahabang melanomas. Okay. So there are complicated disease. Any questions? Okay. So we can go to tumors of cellular migrants to the skin. So, nearing the end na tayo. End your quiz. Okay. So, two entities na naman in the book were mycosis fungoides and mastocytosis. So let's first discuss mycosis fungoides. So mycosis fungoides, why is it called mycosis fungoides? Kasi it was initially found to be a fungal infection. What is that? It's a neoplasm. It's a neoplasm. It's a cutaneous neoplasm of T cells. So it's a cutaneous T cell lymphoma, CTCL. So there are a lot of cutaneous T cell lymphomas. Pero the most common is mycosis fungoides as I said. Okay. Initially, I was a med student. Yung mycosis fungoides and Sézary syndrome were parang part of a spectrum. So, mycosis fungoides can progress to Sézary and vice versa. But that's not the case now. So, when I was resident now in pathology, these are already classified as separate entities because they have varying molecular features. No? But anyway, yun. Yan ang state ko kasi hindi siya masyadong in-emphasize na Robbins. So, mycosis fungoides is separate from Sézary syndrome kasi mycosis fungoides is only limited. The T-cell lymphoma of the skin is limited to the skin. But Sézary syndrome, there is already leukemic involvement. Leukemia na siya. So, it is clonal expansion of your CD4 T cells, no? And affects older individuals, but later, by example ako, it can occur in adults as well, in younger adults and adolescents. So, mycosis fungoides can occurs in stages, no? So there are three main stages: your pre-mitotic, mitotic, and tumor stage. So in the pre-mitotic phase, it's usually difficult to diagnose mycosis fungoides stage kasi they will appear like this, patches lang, scaly patches or plaques that can be mistaken for psoriasis, eczema, On biopsy, it can just appear as spongioses or psoriasis from dermatitis. And if if you don't do IECs or other molecular tests, you will not be able to diagnose it at this stage. So it's a non-specific and non-diagnostic stage. And it will progress to your mycotic stage. No? So this one is your mycotic stage. Mycotic stage. Hyperpigmented plaques. So the trunk, extremities, and the face is usually in this stage. And now your tumor stage na, this will be your nodular growth. Very ugly tumor. But may mga fungal infections na appear like this. That's why biopsy is important. Now, in Sézary syndrome, they have what is this what you call as your erythroderma. So red, namumula ng patient. Namumula ng patient. It shows as generalized redness, erythema with scaling. And nakita naman. And this is one of our patients. So, you can see here, this is mitosis mucoides. You have infiltration or epidermotropism of atypical lymphocytes. So, let's zoom in. Look at the lymphocytes here. Diba? The lymphocytes are round. They're small, they're round, they're darkly staining nuclei. But look at this. No? Different shapes and sizes of lymphocytes. But actually, it's difficult to distinguish it from non-lymphocytes that are infiltrating this tumor. But from a lower magnification, partial inflammatory. There's actually spongiosis here, no? Partial eczema, but it's not because if you go on higher magnification, the cells are very atypical, and they can form this one. Another parang abscess, diba? In psoriasis, diba? You have your Monroe microabscesses. There are neutrophils naman. But this one, in mycosis fungoides, you call this Potier microabscess. Potier microabscess. Now, your atypical lymphocytes that are infiltrating into the epidermis of exocytosis of atypical lymphocytes into the epidermis. Kasi mycosis can be has spongiotic features. It can also have psoriasiform features. But the difference from inflammatory dermatosis is that atypical lymphocytes. Now, if you see this in the biopsy and you know the clinical picture of the patient, you can order immunohistochemistry test, and this is how we confirm it. You can see that it's positive for your typical T cell marker, CD3. And look, CD4 is highly positive kasi clonal expansion of malignant neoplastic CD4 cells. But look at the CD8, negative. So one of the diagnostic criteria actually for mycosis fungoides is we do the ratio of the CD4 to CD8. And if the CD4 to CD8 ratio is more than 10, then that's one of diagnostic criteria for mycosis fungoides. CD8, CD4 ratio of more than 10. Okay. There's usually loss of CD5 and CD7 expression as well. Okay. Sézary syndrome is leukemic. And this is actually yung kaninang biopsy kanina ng skin, and this was the blood picture of the patient naman. So actually, yung patient namin was actually Sézary syndrome. No? Kasi leukemic ang presentation niya. But the question is, did it progress from mycosis to Sézary? Unlikely. It was actually Sézary from the start. This is what you call as your Sézary cells. No? This one is convoluted. So this is from the patient. No? And this one is a classic example. See the convoluted nuclei of these lymphocytes. So these are your Sézary cells. And surprisingly, this was asked during my board exam. Yeah, so mycosis fungoides is my board exam. And wala akong idea na mycosis fungoides will happen sa med school. Kasi may medyo rare din itong but it's a rare tumor, but it's one of the most common tumors na infiltrating tumors to the skin. Your cutaneous T-cell lymphomas. There are a lot of them, yung vaginal reticulosis, yung mga, marami yan sila. But yung mycosis is usually more common. And there's different diagnostic criteria for mycosis and Sézary syndrome. I won't go into that kasi medyo complicated na siya. I'm going off topic. But know that mycosis, tumor of CD4, clonal expansion of CD4 cells, forming polymer microabscesses, it typically possesses the integrated epidermis. And if you see that when you have a patient with leukemic picture, and you see this Sézary cells, these convoluted cells, cells with convoluted nuclei, we call it Sézary syndrome. So usually as more aggressive forms, poor clinical outcome, and our patient actually dies. Any percentage actually erythroderma. Di ba kanina? This one. Erythroderma. So he came into the clinic, red, scaling and erythema all over the body. And WBC count was 300. And when you biopsy the skin and the skin biopsy niya, typical lymphocytes infiltrating the epidermis, polymer microabscesses, IHC, CD4 positive, CD8 negative, and in the blood, peripheral blood smell of Sézary cells. So this was Sézary syndrome. Okay? Questions? Okay. Mastocytosis. So, medyo malapit na tayo. Mastocytosis, rare spectrum of clinical disorders that causes increased number of mast cells. So, mast cells, when the degranulation causes release of histamine, and it causes what? Urticaria. No? So this one is a disorder that causes or tumors that cause increased mast cell production. So usually there are two forms, the cutaneous form and systemic forms. The cutaneous form usually affects children, and it can either be a solitary mastocytosis or a single one, or your urticaria pigmentosa, or more generalized form that's actually in the picture, generalized urticaria in infants. And the systemic one usually have mastocytes in other areas of the body other than the skin, and usually affects adult. So it has acquired mutations in your KIT and PDGFR, platelet-derived growth factor receptor alpha. So PDGFR is also a tyrosine kinase receptor, and remember tyrosine kinase involved in growth factor, cellular growth and metabolism. Okay, so urticaria pigmentosa, common in children. So there are two clinical features here. Sorry, diarrhea sign and dermatographism. So diarrhea sign, when you stroke the skin of the patient, it causes what? Urticaria. So there's erythema swelling just after a few seconds. And dermatographism is when you create, parang if you write the skin, trace something in the patient, nag-ano siya. Ayan. You can see this parang bumps where you stroke the patient, kaya dermatographism. So pwede magsulat dyan. Write your name. Ayan. So this one, more isolated lesion, more in older individuals, solitary mastocytoma, so a pruritic nodule. And what you see in the microscope is this one. So this is not, I just took this from the internet. I've never seen an actual mastocytosis case. So here, you can see mastocytes. It's very difficult to distinguish this from normal lymphocytes or an inflammatory lesion. No? But it has more, this one, pink granules, granular, ang appearance ng mastocytes. You can see mastocytes in dermatofibroma or neurofibromas, other tumors actually, kasi inflammatory cells siya, in urticaria, in eczema. But this one, proliferation of your mastocytes. And you can use special stains here to demonstrate the granules within the sorry, the granules of the mastocytes. So this one uses toluene, ano, toluene glue. And you can also use gem shot. Ito toluene the gem shot. And other tests you can use IAC. So remember your mastocytosis has skin mutations. So they will have this one, expression of CD117 or c-KIT. Kasi overexpression of KIT promotes NF-kappa pathway and cellular proliferation. So here, overexpression of KIT, c-KIT. And this one is tryptase. So this one can differentiate mastocytosis from other inflammatory lesions or inflammation or allergic reaction. So last na lang, other tumors or tumor-like conditions. So I just picked this up kasi common in clinical practice. This is one most common about your pyogenic granuloma. It's not a tumor. Well, it's a tumor, but it's not a neoplastic lesion. There's no mutations involved. This is just a reactive process. When there's trauma, usually it's in the digits or in the lungs, like for people who have braces. What happens is that since there's trauma, there's proliferation of your growth factors, and then you have the hair, granulomas, histiocytes, and within those granulomas are these blood vessels, capillaries. Kaya tinawag siyang pyogenic granuloma. Other name is lobular capillary hemangioma. But it's not actually reactive lang siya. This one, it appears clinically, a reddish papule. Usually in digits or in the oral cavity kung may trauma. Usually may history of trauma yan. So in this patient, biopsy namin sa skull. Apparently may trauma sa skull and became parang nodule na worried na siya it could be cancer. Pero ano lang siya, it's the reactive growth. So, see, reactive growth factor. Not the plastic lesion. This one of our cases also, this is a neurofibroma. So, di ba kanina we talked about dermatofibroma. This one, kasi siya, common in people with neurofibromatosis type 1. So in this case, this was a 12-year-old male who had learning disabilities. It's not the actual patient, but a representation. And he had multiple pedunculated lesions in skin, in the neck area. And meron din siyang learning disability. And what you see here under the microscope, biopsy of the lesion, you have this parang serpentine, parang wavy nuclei. Sorry. Serpentine nuclei. So characteristics of your Schwann cells. Kasi neurofibromas are actually derived from Schwann cells. So you have your neurofibromatosis, there's increased appearance of multiple neurofibromas in the skin, or what you call as your coffee-olay spots. Coffee-olay spots. Cafe-olay spots, sorry. Cafe-olay spots. So, thank you. If you have questions? If you have a question, there's my email and there's my Viber, Telegram, you can ask me questions there. Questions?